those from August to October. I think we may have forgotten to hit record in July, but those from August to October are available on the CDC website right now. And maybe Lisa, if you don't mind dropping that into the chat, or I can in just a moment. They're all available if you'd like to take a look at some of our previous sessions. Today's session will focus on vaccine hesitancy, and I will turn it over to Lisa Letourneau to introduce our wonderful guests.
Terrific. Well, thanks so much, Liana, and thanks everyone for joining. We have several guests today. Dr. Sandra Kraus is a professor and chair of the Department of Family Medicine and Senior Associate Director at the Maryland Center for Health Equity and Leadership, as well as Sana Osman, Community Health Worker at Maine Access Immigrant Network, or Maine as we know it, who also serves on the board of two nonprofit organizations, Consumers for Affordable Healthcare and the Cross-Cultural Community Services Organization. And I'm hopeful that we have Inza Watara joining as well, who is a state refugee health coordinator for Catholic Charities of Maine. I have not seen Inza yet, but I don't know if one of my colleagues is seeing him. There's quite a few people on the call, so hopefully we'll see him soon. We are going to ask people to mute your lines while we're talking here to start out, but then very much want to encourage you to unmute because we want this to be a discussion as well. You can also use the chat and feel free to put comments and questions there. Sandra Quinn, I apologize. Wednesday is my clinical day, and so I'm a little off kilter because I was already seeing patients and don't have your intro right in front of me. That's okay. So I'll let you finish the rest of the introduction. I sincerely apologize for that.
Okay, and you're going to share the screen, right?
I shall share the screen. Yeah, so how about if you start talking while I bring up your...
Okay, good morning, everyone. It's a pleasure to be with you. We had a call a couple weeks ago to plan, so I've been looking forward to this. I am a professor and chair in the Department of Family Science in the School of Public Health, and also senior associate director in the Maryland Center for Health Equity, which does community engaged research and programs with African American and Latinx communities in the Washington, D.C. area. My work for many years has been on vaccine disparities, vaccine acceptance, and interestingly enough, for this moment we're in right now, I started a number of years ago working on, okay, let me get to this, working on public attitudes toward emergency use authorization, which is something we're going to talk about today. So I'm going to share with you some data from our NIH study on flu immunization. That was a large study of African Americans over 800 and whites over 800, nationally representative of those groups. So let's see. There we go. Okay, we know what we're in right now. We are in, as many call it, a wildfire. And so the push for flu vaccine could not be more urgent because it will not just protect the individual and their families, but it will protect our healthcare system by reducing some of the burden on healthcare providers. And today, Pfizer announced even more data as they're finishing some of their data analysis with 95% effectiveness and no serious side effects. So we have some interesting days ahead of us, shall we say, as we address this. So I'm going to share with you data from a large national survey, as I indicated. We also did qualitative work, 9 focus groups with whites and African Americans separately. We also did extensive individual interviews as well. And I'm going to go through this fairly quickly. But here are some of the major points that I think are pertinent to those of you that are either providers, community health workers, and in the Department of Health. We're not surprising, perceived disease risk of the flu was a significant predictor for vaccine uptake. But the unique thing we found was that African Americans had a higher perceived risk of vaccine side effects. And in our qualitative work, what we heard was they saw them as being much more serious. So they report, I know somebody that died from getting a flu vaccine. And certainly we know that if people perceive the disease risk as high, they're more likely to get vaccinated. However, when that perceived risk of vaccine side effects starts to rise, then that depresses uptake. So that's an important point. We'll come back in a moment. Now, I didn't touch that, so I'm a little worried here. Okay. Are you doing that, Lisa?
Yes, I am controlling the slides right
Okay,
now because I'm sharing screen. So yes, and
Okay,
I'm just
great.
kind of anticipating when you change, but if you want to say next, that's fine.
Next is fine. Okay. So we will come back to this later. Next slide, please.
There seems to be a little bit of a lag sometimes. I'm sorry, I don't know
Yeah.
what's going on. If I have to get out of screen share, sometimes it just gets stuck for some reason.
Okay. I'm trying to think of what's coming next.
I think I need to get out of screen share. Sorry. Okay.
Okay. That's what I thought was coming next. So because we had large samples of whites and African Americans, we heard the groups really kind of talking very much from a lived racial experience in our country. And what I mean by that is that whites seem to have sort of much less of a skeptical or questioning response to the flu vaccine, like it was family history to do it. But for African Americans, it was quite different. So we developed a set of measures, and they were structured in such a way that I, as a white woman, could answer based on my perspective, and an African American person could answer based on their lived experience. And we were looking at issues of perceived racial fairness in the healthcare setting, racial consciousness in the healthcare setting, and discrimination in the healthcare setting, not broader society, only healthcare. And do you feel like you're being treated fairly? If you're an African American and a provider's office, how conscious are you of your race? For example, if you may be the only patient and the staff is all white or patients are white. And what we found is that perceived racial fairness was associated with more trust in the vaccine and higher vaccine uptake. But perceived racial consciousness, the higher that was, the more somebody was really conscious of their race. This was in a healthcare setting. The lower was associated with lower trust in the flu vaccine and the flu vaccine process, and I'll talk about that in a minute. Higher perceived risk of side effects, less knowledge, and greater hesitancy. And finally, if they perceived that they had experienced discrimination in the healthcare setting, again, that was associated with higher perceived risk and lower uptake. Now, these are factors that I think more and more healthcare settings, health professional schools are looking at implicit bias and trying to address some of these issues. Next slide, please. We also found that our participants just didn't understand kind of what was the process for the flu vaccine. And so we created an infographic, we tested it, that really started with, who's involved in approving vaccine strains, and then the roles of CDC, FDA, down to the provider that literally puts the injection in your arm. And what we found was that African Americans had lower trust in all the organizations, but the rank order was the same as whites. And not surprisingly, doctors, their own healthcare provider, were the most trusted, CDC, FDA, and there was a pretty universal negative response among both groups to drug companies. We also found that the more trust they had in the process and the vaccine itself, the higher their uptake. So understanding this process, and now we're faced with, talking about a very different process for the COVID vaccine. We'll talk more about that in a minute. Go ahead. But there were some other things that predicted trust in the vaccine. So it's kind of an interesting interaction. So if they perceive risk affects trust in the vaccine, perceived effectiveness of the vaccine, the importance of the vaccine. Do they think it's important for them? And finally, there was another thing that we asked based on our qualitative work. In our quantitative work, we asked, what proportion of people close to you do you believe wants you to get the flu vaccine? And the higher the proportion of people they thought wanted them to get the flu vaccine, that was a predictor, we call it subjective norms, predictor of trust in the vaccine and the process. Whites tended to, if they questioned trust, it was trust in competence of government. For African Americans, it was trust in motives. Did they trust that the government's actions would be in their best interest? And so their trust was lower. But we also heard that often for whites, it was more of a kind of a passive acceptance. But for African Americans, many of them talked about really juggling sort of in a very active process. Am I going to let go of fears of like the legacy of the Tuskegee syphilis study, fears related to government, and step out on faith and take the vaccine? So it was much more of a deliberative process at times. Next slide. And trust in the vaccine, not surprisingly, was associated with confidence in the safety and effectiveness, convenience, and negatively associated with complacency. So if they did not think it was important to them, that it mattered that they got it, is that what we refer to as complacency and hesitancy. We asked about whether they got the vaccine the year we gave the survey and for the 5 years previously. How often did they get it? Every year, most years, once or twice, not at all. And obviously, not surprisingly, higher confidence in the vaccine meant they were more likely to get it. And that's something we'll talk about again in a moment. Next slide. Social norms out, and I think this is important. This is going to be important when we start talking about COVID vaccine too, that believing people want you to get it, that are close to you, is important. But for African Americans in particular, especially those that got vaccinated most years or every year, they had a much higher belief in their moral obligation to other people to get a flu vaccine. That was a significant predictor for them. And so I also think that's something we will have to come back to during COVID as well. Next slide. So what do we do to increase trust and confidence and uptake? Next slide. So some of you are with the Department of Health, and I think there are a couple of things that public health agencies can do. Oftentimes we talk about the perceived risk of the disease, right? And what we found in our study was that their knowledge of flu, their knowledge of the vaccine, the process, and recommendations, that the higher their knowledge was in these areas, the more trust and confidence they had in the vaccine. So I think it calls upon us to speak to those things more specifically. Certainly we need to address perceived risk of vaccine side effects, because we know that by and large they are mild. They're not necessarily perceived that way, and by focusing on disease risk and not side effect risk as frequently, we're missing an opportunity, particularly with African Americans. I think this year, the benefits of the vaccine, not just for themselves, but again, to protect our healthcare providers and system, I think is really an important message. And finally, we did find more concern about cost among African Americans. So I think not just acknowledging cost, but minimizing cost, increasing convenience, and now, creating opportunities to get it in places that are perceived as safe. So I'm working with Black churches in Baltimore, and where the health department is taking their van out to some church parking lots so that people can line up outside and then just go in the van for a few moments to get their vaccine. So next slide. Healthcare providers, and I know a number of you are providers of different types. And so whether you're a physician, a nurse, a community health worker, a pharmacist, this is the year more than any other, both for flu vaccine and for COVID, that it's really vital for everyone to work together to get those clinics out into communities. I was fortunate. My primary care doctor has a system. You get to the office, you call in from your car, they come out, I stick my arm out, I've got my mask, they've got my mask, their mask, I stick my arm out the window, I get my vaccine, and I'm done. But I think we have to be very creative and collaborative in how we do that. But the other thing we heard from our data is that the providers' recommendations are vitally important. They trust their providers. And yet I also know that providers themselves don't always get the vaccine. So I think being a role model for flu vaccine, and as we go into COVID vaccine, will be very important. The other thing we know from some of the literature is even when African Americans are more likely to have a visit during the season, they may not get a recommendation and an offer. And so getting that, not just recommendation, but the offer at the exact same time is vitally important. So let's talk about that in the next slide. So one of my colleagues, David Barniatowski, proposed a framework for communication. And we know that our patients, your patients, may have myths about the flu vaccine or hesitancy. So it starts with a verbatim fact, some evidence-based fact or statistic, but then it links to your patient that's in front of you, or if you're a community health worker talking out in the community, people, to a phrase that is something like, the reason this is important for you, what this means to you, what I want my patients to remember is, and then a bottom line meeting. Hit the next button, Lisa. Okay. So for example, I'm focusing right now on the side effects. I'm getting that message in, but this is a fact. We know it's approved annually and it's safe with only minor side effects. The reason that's important to you is that with your type 2 diabetes, with your asthma, whatever that may be, you're more likely to have serious complications if you get the flu. I strongly recommend you take it today, and I can give it to you right now. That's very different from what, people have said to us of, do you want the flu vaccine? It's very easy to say, no, I never get the flu. So much more sort of an assertive approach. Next slide. So now we're in a COVID period, and we know that there's been enormous sort of coverage of hesitancy about the vaccine, skepticism about the vaccine among the general public, as well as among Black and Latinx and Indigenous Americans. Today, Kaiser just announced 95% effectiveness. So Kaiser and Moderna are on their way to submitting applications to the FDA for emergency use authorization. So I want to transition here to talk a little bit about what that means, because it's not something we know as much about, although we've certainly had some lessons across these last couple of months. Next slide. I'm going to share with you, this is data from a 2009 and 2010. I had a CDC grant, National Representative Survey, 1,600 whites, African Americans, and Latinx participants. And we asked them about, because First, we thought the H1N1 vaccine might have to go through the EUA processes. Turns out it didn't. But we asked them, would they take a vaccine that went through that process? We also asked them, would they take Tamiflu was approved for a different population. There were some drugs, antivirals approved then. So here's some of what we learned. So hit the button. So if they were worried, the higher their level of worry about the vaccine or drug, the less likely they were to take the vaccine or take the drug. Next, hit it again. If they trusted government actions, not in general, but during the pandemic, they were more likely to take one of the drugs that was approved. Next. Higher perceived personal consequences. So in that we had perceived susceptibility, severity, they were willing to take the drug. Next. If they got the flu vaccine annually, if that was a health habit that they were consistent in, they were more likely to take the vaccine and drug. Yet we know most of the public doesn't get the flu vaccine annually, right? Next slide. So we've got a couple of challenges here. I mean, many healthcare providers will not know a lot about the EUA mechanism, the emergency use authorization mechanism, which was put into place exactly for moments like this, when we had a public health emergency with the need to create new vaccines or drugs or approve others that were already approved for use. And we've certainly heard documented concerns and reluctance even among healthcare providers. And I'm focused on providers here. I could say the same thing about African Americans. I can say the same thing here about the general public. They don't know much about it. They're going to be concerned, and we've certainly seen high document reluctance or skepticism. Next slide. One of the challenges is we did a study for FDA with whites, African Americans, and Latinx people, qualitative study. We created a scenario of a hypothetical respiratory disease. Then we took fact sheets that were used in other emergency use authorizations, because that's what providers will get and that's what a patient will get, a fact sheet. And we took those fact sheets, we just tailored them to use the language of our hypothetical situation. And then we tested them with our participants. And what we found is there was very limited understanding of the kind of terminology used for novel drugs and EUA authorization. And we'll talk about that more in a moment. But there are certain terms used that asking them to free associate with what they saw. Things like experimental, accelerated approval, off-label, prompted strong negative reactions. Even the phrase emergency use authorization prompted mixed responses, from important and helpful, which is more positive, to risky, suspicious, desperate. And everyone said they needed more information to make a decision about whether they would take the vaccine in this hypothetical scenario. Next slide, please, Lisa. So I'm sharing this, and the reason I'm doing this today is I think we need to start thinking now about how we educate African Americans, our general population, and how we educate ourselves as providers of different types. This is directly from the remdesivir fact sheet, and I want to just show you a few things here so you're starting to get familiar with this. What do you see in the first sentence? Investigational. And we know for African Americans in particular, but not solely them, that can trigger, the Tuskegee syphilis study and Henrietta Lacks and fears of being a guinea pig. It's investigational, still being studied. Oh, I don't want to be a guinea pig. Limited information about safety and effectiveness. Next slide. And then the fact sheet tells you what an EUA is. And I just highlighted some of the language. It's not undergone the same type of review as an FDA approved or cleared product. In the next paragraph, it's reasonable to believe that the product meets certain criteria for safety, performance, and labeling and may be effective. So Couple of things here for you to be thinking about with regard to African Americans and really I think everyone in this situation. Is this language, the readability of these fact sheets is challenging. The language is going to trigger some negative response and skepticism that we, whether we're public health providers, public health practitioners, healthcare providers, are going to need to be familiar with that language and able to address it. So these are some of the challenges coming to us pretty quickly. Next slide.
It's weirdly frozen again.
You know, I'm amazed considering that, you know, much of the world is functioning on Zoom, that things actually work as well as they do most of the time.
I don't know. It's like, there we go. Okay.
Okay, so let's talk about what we can do for providers. And again, I mean this broadly: healthcare, public health practitioners, community health workers, etc. Hit the next. I think there will be lots of questions about the clinical trial process, and some people are more familiar with it than others, but it certainly has moved faster, and that is going to engender questions. So we're going to have to help our providers and our practitioners be ready to answer those questions next. And get them familiar with what this EUA means, what these fact sheets look like, because they're going to raise questions. And, you know, most of us don't have a lot of familiarity with them. And so that's going to be important to help address the public's and patient questions. Next one. I think having really clear access to some of the data, all of these sponsors for the trials will be releasing their reports, but knowing some of the data on safety and efficacy, and then how the ongoing safety monitoring will occur, I think will be important in terms of talking to whether we're out in the community or we're in a clinic. Next. The other thing is, you know, the first two vaccines are mRNA platform vaccines. The others are different, and even the first two both have 2 doses, but one at 21 days, one at 28 days. So it's an enormous administrative and logistical challenge, but it will be a challenge also, you know, for providers and practitioners to be able to understand what these options are and what they mean to the public. Next. So I'm going to stop now. We all know we wake up every morning, we go to bed every night, knowing that we are in a frightening scenario right now across the country and across the world. So I thank you for your attention, and I look forward to hearing from the panel and talking.
Super. Well, thank you so much, Dr. Krause. That was incredibly timely and informative, and really just speaking right to some of these issues. And with that, we wanted to transition to our 2 panelists from the community. So Sana Osman, I mentioned, community health worker with the Maine Access Immigrant Network, or Maine. And then Inza Watara from the State Refugee Health Coordinator from Catholic Charities of Maine. Inza, feel free to, I'm going to actually make you co-host as well so you can see the chat. But Sana, I see that you are unmuted. But how about if we ask you to jump in? We've asked Sana and Inza to speak to us from the voice of the community about what they're hearing, what concerns they have, and recommendations, thoughts for the provider community, particularly in getting ready to address these issues. And then we'll open it up to questions. Again, you can either chat or unmute as we go. Sana?
Good morning, everyone. Thank you so much, Lisa, for inviting me to be a part of this panel. Again, my name is Sana Osman. I'm a community health worker at Maine Access Immigrant Network. It's a nonprofit organization It's a health worker organization, nonprofit health worker organization, and we do public health advocacy, research, case management, and community health education. Our team consists of 6 community health workers. We speak the languages or the multiple languages spoken in the greater Portland area. We have 2 Somali speakers, 2 French speakers, 2 Arabic speakers, and I am one of the Arabic speakers. We also have a program assistant who's from Djibouti and speaks Somali and French, and our executive director also from Somalia. And the board consists of all immigrants and refugees. And of course, our director is from Vermont. So. Our organization provides services for immigrants and refugees in the area. It started out as Somali Culture and Development. That was back in 2008 when there was an influx of Somali community coming into Maine. And then in 2014, when we received the grant from the Office of Refugee Resettlement, that's when Mahmoud Barri, our executive director, expanded the program. And then we joined in and started serving other communities. So in preparation for this panel today, first I asked my multinational community that I work with in Maine at our organization. And then as a member of several language specific groups on social media with platforms being used to share information about this pandemic, I posted a few questions to the groups on some of these social media platforms. I asked people how they felt about COVID-19 vaccine and what people believe the medical provider needs to do to gain their trust or to be able for them to take the vaccine. One of these social media groups has about 10,000 followers. The other one has about 3,000 followers. And within like an hour of posting these questions, I had like 170 replies, and they're still replying as we speak. So I also polled participants over our pandemic-initiated Ask the Doctor series that we conduct at Maine. And of course, it's virtually, it's over Zoom. And we have a weekly session with a partner provider, physician. We talk always about COVID-19 and the flu vaccine, and it's conducted in different languages where we translate or interpret the languages that we speak. So what I'm going to share with you today is sampling of the responses I've collected over the past couple of weeks from these language communities. Most of the answers provided were against taking the vaccine, and for a variety of reasons. Keep in mind that in these closed group, it consists of people from different backgrounds, from different education levels, and also from different parts of Africa. Some responses were in Arabic, and I had to translate these responses. I'm going to start with this first one. I'm quoting this person where she said, for any vaccine to be produced and sold, it goes through different stages and it has to be tested on people from different ages, different ethnicities, and a lot of vaccines take between 5 to 10 years to produce. And for me to take a vaccine that is as recent and as new as COVID-19 is, it is going to be very hard. I would rather face the disease itself and then take the vaccine that has no guarantee on the type of long-term side effects that I will be experiencing. One other person shared that I am concerned that this vaccine was developed in a short period of time and under the pressure of a US president who is always undermining the experts and science. So I don't trust that it was developed in a way that is safe for me or my family to take. I would rather continue on taking precautions like wearing a mask, social distancing, and trying to strengthen my immune system. Another response was, I feel like the authorities has not given the issue of immigrants who have been hit the hardest by this virus in so many different ways enough attention. People need to be educated on more aware about what this virus and this vaccine are. And no wonder almost everyone here doesn't feel comfortable enough to take this vaccine. Another person said that she works in a lab in a hospital. And she said that if it came to the point where a medical provider is mandated to take the vaccine and give it to, or maybe give it to their children, I would quit. Frankly, I feel that we do not know enough information about the virus itself, and we're unable to develop a safe vaccine on the long term. And I have a person who brought up the Tuskegee experiment, and I heard that from Dr. Quinn, and how he's worried that it could be tested on immigrants and even on Africans back home where we come from. So after Pfizer pronounced that it had produced a vaccine, these questions were before the introduction of the vaccine by Pfizer. So I went back and I talked to them about this vaccine and that it's 90% effective. So what do you guys think? I went back and I posted another question, which is, would you take this vaccine now that Pfizer has said this or introduced this vaccine? And so one person felt like the news being produced in a regular news release versus being quoted in a medical journal caused them to feel concerned about the validity of the 90% efficacy rate. Since the article says that this efficacy rate could change as the trial goes on, this is proof enough for me not to take it. And others were concerned that they won't know for years the long-term side effects of this vaccine. Another person spoke about how this vaccine that was produced needed to be refrigerated under a negative 80 degrees at all times. And they felt that storage requirements are kind of impossible when it comes to transporting this vaccine. And thinking, especially when they think, because that person was talking about, especially when you think about our home countries, where we come from, and how this vaccine is going to be transported in Africa, for example. Although maybe the new Moderna vaccine that came out on Monday kind of resolves or proposes a resolution for that issue. Almost everyone who answered my questions said that they might change their mind in 5 or maybe 10 years from now. And that is if they see people that would take the vaccine and if they feel like their providers know more about COVID-19 and about the vaccine itself, they might feel more comfortable. And if they think that their providers know about the side effects and they have taken it themselves, they might take it. There were a limited number of people who said that they're willing to take the vaccine as of right now, and as long as it's FDA approved, as long as our medical provider recommends it. I also had people who said, a person who said, I'm willing to take it if they start out with our politicians first, and then I see them taking it. Another comment that was someone who said no, because I don't want to be watching TV in a couple of years and an ad comes up and it says, if you have taken COVID-19 vaccine and experienced this and that side effect, please call this 1-800 number to file a claim against the pharmaceutical company. So in conclusion, and through all these comments that I've read for you guys, after going through all the comments, I think it is hard to convince the immigrant community to take the vaccine, considering how new it is. And as demonstrated through these comments I've shared with you, the only thing that would make people trust this vaccine is time and learning more and getting more educated about the vaccine and the trials and how it is approved and the process of vaccine getting approved. Also, the credibility of pharmaceutical companies is a big deal for our immigrant community. It's based on the history of every company that produces a vaccine. Some of these pharmaceutical companies have tainted history that is well known by some of us from different parts of the world, because we have seen the company inappropriately test a vaccine or a medication on other marginalized communities. Thank you so much again, and I'll leave it to Enza to continue.
Great. Thanks, Sana. That was a sobering and very insightful set of reflections. So, Enza, would you like to add from your perspective?
Yes, thank you very much, Sana. I think Sana has covered a lot in the perspective of the population, directly from the population. But I will, my research was on based on just discussion with my peers across the state, because state refugee health coordinators are in all the 50 states, and we have a monthly meetings. And I just brought that question out there in one of the meetings, and to see what my colleagues are hearing from the refugees and immigrant population out there in other states. So what came up, few points came up. You know, some people may be asking, for example, why should I take the vaccine? Why should I hurry and take a vaccine now when there are, measures, for not catching COVID, for example? I will keep wearing my mask, I will keep social distancing, and I will wait and see. So why do we rush to take a vaccine now? So, and another, issue that came up, it was like, there's no the diversity in the clinical trial, for example, the populations that did the clinical trial. Are there people that look like me among these populations? And I think somebody sent me a slide from a conference where they were kind of talking about the participant in the clinical trial. And I was disappointed to see that, well, the diversity was a little bit lower. You had very few people from South Africa, I think, that from the perspective of the population we work with. So And also some of my colleagues said that, that might bring the issue of maybe the vaccine may be safer for some population and maybe not be safer for some population. That may be a question that, our population may be asking themselves. So also the idea that there will be different vaccine, from different different pharmaceutical company may bring about the same question that we have been having, all over the place. Like, some vaccine are good, some vaccine are bad, or some vaccine are the best, some are of lower grade. So maybe which vaccine are they going to give me? Why are they giving me this vaccine? So these are all questions that need to be answered. So, but at the end of the discussion, sometimes it's like we all came to the conclusion that maybe we should just find a way to build trust. Maybe we should all find a way to have, communications about this vaccine, in terms that will probably help the immigrant and refugee population understand. And when I was listening to Dr. Quinn also this morning, I was like, she kept referring to African American. I feel like asking the question, but were there any refugees and immigrants in the participant population, for example? That could probably help, the population that we are working with here in Maine in building in the trust building process. So, and also another thing that people were also, my colleagues and I were discussing is like, okay, how do we roll out this vaccine in such, environment full of, controversy? So some suggestion were, okay, how about doing like community focus group, for example, with the people that we feel that they will be hesitant. And I need to stress here that, this vaccine hesitancy is not only from my perspective, it's not only from the minority population. In a discussion, I heard even some providers, some healthcare providers agreeing that they will not take this vaccine now. So if we are hearing that from even providers themselves, so that brings a lot of questions. So I think outreaching and a community focus group also may be a way to kind of understand better, how this vaccine will be successfully rolled out. Because these are all information we are picking here and there from conferences and from meetings. And I'm not sure, here in Maine, for example, if we can hear more from the community to be able to address. And another thing is, some people suggested like looking for trusted voice in the community to help roll the vaccine and mitigate the vaccine hesitancy. Like some refugees and immigrant community, have, former doctors from country of origin, former nurses from country of origin. If these people can be bring into the process of rolling out the vaccine to see how to, better explain what it is, maybe more, we could have more participation. And also, I participated in another conference where I heard that maybe the virus, the live virus, the virus that's within the vaccine, if it's a live virus or, not a live virus, I don't know what is in the vaccine. If that information can also be given to the population to let them know that what is in the vaccine may not cause COVID, or even if you take it, they're putting something in you, but it's not gonna make you, it's not gonna kill you or something, If that information can also be out there, that might help people probably reconsider or think about if they want to take it or not. So that's what I could, that's what I have for today.
Fantastic. Great suggestions. And with that, I'd love to open it up. We've had several comments. I don't know, Dr. Quinn, if you have a response to anything from Sana or Inza. Several suggestions here, but we can open it up for questions too.
Let me just ask that first. I think, what you have both shared is both is in many ways not surprising to me. And so you said, this is not just immigrant communities. You're right. Healthcare providers and many whites. I mean, there's skepticism that was engendered by the very term Operation Warp Speed. That sort of, created red flags for many people. My question to both of you would be, there a lot of what you talked about in terms of questions and concerns, some of those things are knowable, like who was in the trials, what was in the vaccines, why the trials moved quickly, because there are some really legitimate reasons why they moved quickly. How was safety, how was independent decision making brought into the process, so it was not just the companies themselves. How much do you think that, because we can't change the issue of time that you talked about needing to see it over time, how much would knowing those things make a difference?
I will take a simple example. If I think you would, you would convince me to take something, or you convince me to get into something if I especially in this particular case of the vaccination, I might be maybe convinced if I know that, oh, this vaccine was tried on somebody that looks like me and the person has been doing fine, or what is in the vaccine is not actually going to kill me. It's just to to keep me safe, and whatever is coming out of it, I guarantee you nothing's going to happen to you. It's not, this vaccine is going to be the cause of you dying, in 2 or 3 months. If you assure me that, and then I know what is, why the vaccine is being created for, and the COVID is around, maybe you would probably convince me in taking this vaccine. That's why I think it's important to explain those things to people, because we have just conducted, even I think Sana is part of that project. We have just conducted something, a photo voice project on the impact of COVID and on African immigrant. And we discovered in those discussions, it was like some kind of focus group discussion. We discovered that people have their own way, of dealing with this COVID or this pandemic. And I don't think a vaccine that does not kind of fall into the context or their own perception, will change that. So you have to be able to convince people that, yes, the vaccine can be added to what you are doing and then make you, keep you safer. So that's why those things are important. What is inside this vaccine? And say it in a term that is very simple for people to understand. How many people were that look like you that were tried? That were in the trial. Okay, and if I personally saw in some news where people that participated in the trial came and spoke. For example, I've seen a couple of people that were participating in the clinical trial that spoke about the vaccine that came in, and they don't look like me. So, for example, I would say that, well, maybe for him it works best. Maybe for me it will not work best if it wouldn't work. So these are all important things that to talk about that will help people.
And I just want to add to what Enza said, is just when role models, or like when your provider takes a vaccine, as you said, or when politicians maybe at that comment, it might be funny to see, some people said, if Trump took it, I'll take it, and he's alive. So things like that, I think it does make a difference to people to see someone who's a role model to them, or a provider, and the closest provider to them, their own doctor, taking it. And just having some transparency, knowing more information, and knowing about the process itself of, like, expediting a vaccine doesn't mean that it's not as efficient if it's done in a short period of time. This is very important for people to know, because a lot of people brought this up, like vaccines take between 5 to 10 years. Why is this taking 6 months or 7 months to come out? And the way it came out, because it came around the elections, and all this worried people about this vaccine. So we need to have people have some more trust in the process itself and how it is conducted. So that's very important.
So there's some great comments in here as well. Politicians and providers taking it. What about religious leaders and political leaders as well? Great conversation to be had there. And then Fran Jensen, our Medicaid medical director, had asked the question about, we often hear people say about flu vaccine, right? So we've had our own challenges with flu vaccine, never mind COVID, but I don't get the flu vaccine because I get flu when I get it. How would we address concerns like that? Dr. Quinn, any thoughts on that one?
Yeah, I think that's a really common myth, that I get the flu when I take the vaccine. And, we all know that the flu vaccine really doesn't have live virus. It can't actually give you the flu. But what it can do as your immune response kicks in is make you feel feverish for a day, or make you, not feel great for a day or two. If you get a full-blown case of the flu after, it may be that you were infected before you even got the vaccine. I mean, yes, we know that the effectiveness varies from year to year, but I think the key thing is there's no live virus to actually make you get the flu in the vaccine.
So being able to explain facts like that for COVID, and to Inza's point earlier, what are the components in this one? This one is almost exponentially more complicated, right?
Yeah.
In terms of the various methods and which ones, and what's involved in them. To that point, I thought it might also, love to have more questions, but it might also be helpful, Liana, if you and I talk just a few minutes about what is planned from DHHS around some of these concerns as well, just to let folks be aware of that. But let me open it up for a minute before we do that for other questions or comments.
So do you mind if I throw out a question for our panelists as well? We've talked a little bit about the statistics here in Maine related to COVID-19, and while we saw a huge number of cases for the Black community, relative to the number of cases, hospitalization and death rates were relatively low, in large part probably because our population of color skews younger, and we know the virus has a much more significant impact on older populations. Does that reality impact this cost-benefit analysis that people are going to do about how bad is it to get sick versus how bad is it to take a vaccine that I don't fully trust? And how do we talk about the racial and ethnic disparity of COVID cases, taking that very seriously, and not lose sight of that difference may actually be weighing into this cost-benefit analysis here in Maine specifically?
Yeah, can I say something in response to that? I think part of the issue is that yes, there may be a difference because the population's younger, but what we know about COVID, and granted we're learning new things every day, is that for many people, the disease, even if they're not hospitalized, even if they're not that severely ill, can have long-term impacts. People who never actually went to a hospital, but still months later are sick. And so I think that's something for people to think about, is you don't have to die for this to have a significant impact on your life, on your family, on your livelihood. Because I also think of the communities where, because of their work setting, they don't have sick leave. If they're not working, they're not getting paid. And so, I think that's another thing to help people understand is you don't have to be hospitalized for this to have a serious impact on your life and your livelihood.
That's a really good point. Yep.
Also, I'd just like to add that we need to point out that how highly contagious COVID is. So if you are a younger person and it wasn't that severe for you, you have a parent, you have a grandparent, you have a family member who has a weaker immune system, who's older and is not going to be able to tolerate the disease as well as you did. So this has to be brought up to people, to the community, that if you were able to get the mild side of the disease, someone else might get get it in, it will be very hard on them. And it's not just long term, it will be at the first, even experiencing the disease or getting the disease is going to be really hard. It's going to hit them really hard. So this needs to, if they don't care as much for themselves, you have to think about the other family members, other people in your family.
And to that point, I was really struck, I think it was Dr. Quinn, in your presentation about the feeling of responsibility to the community around flu vaccine, that people from communities of color were more likely to say that than the white population. So I wonder if that might be another important thing, particularly given how many people in this state from communities of color work in healthcare settings, long-term care, home care, et cetera. So probably an important point to leverage.
Yes.
And with that, it's 8:29. So thank you all. Leanna, you want to say just a few words about what we're planning, and I can talk about the provider side?
Sure, although I think Enzo was trying to make a comment.
Oh, sorry, I didn't see that.
Yeah, I mean, I wanted to just say that it will be important to probably develop some language, some communication language and strategies for the community of, I mean, the minority communities in Maine to be able to work on this. So that's all.
Thank you.
Yes, and so because we have 1 minute, I'll give the very short answer, which is yes, 100%. We hear you and we agree with you that we need to do that specifically. And so we are working with our immunization team, and as well as DHHS and the CDC are working together to think about how we begin that work. It will obviously begin with some of the folks who have been working on the ground with us through the Health Equity Initiative, and making sure that our partners are brought up to speed on all of the questions that you raised here today, so that they can be advocates for this when it is time, but also helping us to make sure that the concerns from the communities are rising up and are being heard by our immunization team. So thank you.
And then I'll just join in to say that we are starting up an effort to convene a clinician work group to start planning for clinician education. I think we've heard loud and clear, and I've certainly had my own serious concerns that the clinician community does not understand what's been involved in the approval, all the issues that have been brought up today. So we will be coming out with more information there. So thank you so much again, all of our presenters, Dr. Quinn, Sana, Inza, everybody for joining us today. We will, as Leanna noted at the outset, post this recording as we have, and I forgot, Leanna, to put the link in, but it's on the Maine CDC.
I put the link in earlier in the chat.
Did. Okay, thank you.
And again now.
Okay, thank you. You just have to scroll all the way down, and then you'll see a little slide of the presentation. We initially had said we were going to be doing these monthly until now, and then quarterly, but we have decided to keep these going monthly. The next one will be again the third Wednesday, so December 16th at 7:30 in the morning, and we will be focusing again on the COVID vaccine. Anticipating that we'll even know more by then, and continuing this conversation about how to build trust and maybe more about the mechanics of what's happening in Maine as well. So thank you all. Stay safe. Thank you for your good hard work on the ground and for all your insights today. We really appreciate it. Take care.
Thank you. Bye.
Lisa, did we save the chat?